coming to the types of incisions. Actually, these type of incisions are very important even if you are going for a septorhinoplasty or as for theory examination. This can be asked as short notes. So, coming to the incisions, there are actually 5 types of incisions commonly used. One is an intercartilaginous. That is, we put it between, this one is the upper lateral cartilage. So, if you want to know the anatomy of external nose, this external nasal framework, it was already taken in a class. Please go through the previous videos on anatomy of external nose. Without knowing that, it will be difficult for you to identify the different cartilages and also the nasal bony area. Okay, so the intercartilaginous incision goes between the upper lateral, this is upper lateral and this is lower lateral cartilage. So between the upper lateral and the lower lateral cartilage, it goes like this, between the upper lateral and the lower lateral. And mind you, we do that inside. There is no external incision for this. So this is usually done through the nose, inside the nose. So between the upper and lower lateral cartilage. And this advantage is that this can be connected to membranous septal incision for septal exposure. So if you want to go for a septal exposure along with the rhinoplasty, so this incision can be connected inside. This can be connected to the membranous septal incision. Okay, and this is basically done for patients requiring little or no lobule modification. So lobule means this area downwards. So alar area, tip area, if there is no involvement of the tip, there is no involvement of the alar region, or the patient does not require a lobule modification, then you can choose this incision. And advantage is that this is least undermining and this preserves the interdermal and intercartilaginous ligaments. So ligaments are not touched through this. So it preserves that, and also there is least undermining. But if you go for an external rhinoplasty columellar incision, there is high need of an undermining of the tissues are there. So here there is least undermining of the tissues. And access to the dorsum is easily obtained through this approach. See, I am going through this, and through the intercartilaginous incision, the external dorsum can be reached very easily. So this is intercartilaginous incision. The next one is transcartilaginous. What is that? Transcartilaginous. That means this is going through the cartilage. Through which cartilage? Through lower lateral cartilage. Okay, so it comes like this, through the lower lateral. This one is lower lateral cartilage. So transcartilaginous incision. Again, this is an approach to dorsum of the nose. There are all the advantages of this intercartilaginous incision are there. Plus, it has got 2 additional advantages. What are they? One, if there is minimal lobule modification is needed, we can go through this. But if there is for intercartilaginous incision, we cannot go for a lobule modification. But for minimal lobule modification, this transcartilaginous incision can be used. And also, there is no risk of a web scar formation in the area of internal nasal valve. But in an intercartilaginous incision, there is chance of, if not done carefully, there is chance of a web formation in the internal nasal valve area. So that risk is not there in case of a transcartilaginous incision. Okay, and this is more accurate. Actually, this incision is more accurate than that of an intercartilaginous incision. Next one is an infracartilaginous approach. Infracartilaginous. That means below the cartilage. Below which cartilage? Below the lower lateral cartilage. Okay, so actually it goes like this. Below the lower lateral cartilage. It goes like this. Okay, so it goes along the caudal border of the alar cartilage, and this can be extended along the columella caudal to the medial crura. If this is the columella, it can be extended into the columella. So that what is the advantage of that? This can be converted to an open approach. So this can be converted to an open approach but without incision over the columella. Okay, so that is the advantage of this one. But this is useful only in minority of patients, and this is a very poor choice in patients with a very small nostril, and this gives a very good exposure of the alar complex. This alar area exposure is very good and without incision over the columella. Okay, but the dorsal axis is very much limited. That is a disadvantage of this. That is why this is useful only in very minority of patients. If you want to go to the dorsum, we cannot go through an infracartilaginous approach. Okay, and it has same undermining of the tissue as similar to that of an open approach. So the only advantage is that there is no incision over the columella, but exposure to the dorsum is limited, and this is done only in a minority of patients. Alar incision, which is done along the ala of nose, along this area. Okay, so along the ala of nose, and ideally or most commonly this is done along with the reconstructions of the nose and not solely for rhinoplasty, along with other nasal or facial reconstructive procedures. And next one is an open approach or columellar incision for open rhinoplasty. That we put over the columella of the nose. If I draw here, I will draw it here. Okay. Columella, and we put the incision like this. Okay. So on the columella, and this is extended, and patients who have got a very small nostril or need extensive reconstructions along with a difficult septum, we prefer a columella or an open rhinoplasty approach. And for this, the advantage is that we elevate here. Okay, if the all the nasal structures, both bony as well as bony septum, nasal septum, bone, then upper lateral cartilage and lower lateral cartilage, everything can be exposed. There is excellent exposure by this approach and demonstrate the anatomy in a very clearest fashion. Okay, and also you can place the graft and sutures in a very perfect way. So perfect placement of the graft and sutures if needed, and also this is an excellent teaching learning tool. The demonstrator can teach this in a very good fashion, and the disadvantage is that one is a columellar scar, and also there is extensive undermining. Okay, so these are the 5 types of incisions used in rhinoplasty. Next is osteotomies. So after incision comes osteotomy. That is also important for your theory exam. Here you can see the nasal bone along with the upper lateral cartilage and the lower lateral cartilage, and this green shaded is a nasal septum. So imagine I have done cut off this area. Imagine there was a hump, and I did a hump reduction. So after making a reduction in the hump, chiseling the hump, it becomes an open nose. Okay, so the upper lateral cartilage and the upper lateral cartilage of both sides, and along with the septum in the midline, and also the lower lateral cartilage, the lateral crest and the medial crest, and these are the 2 orbit along with the nasal bones. So there are mainly 3 indications for an osteotomy. One is like this. After doing a dorsal hump surgery, there is an open roof deformity of either the cartilaginous part, as you can see here, or it can also be in the bony part. So open roof deformity. So indication of one is an open roof deformity. So for closing this open roof deformity, you have to make approximation in the midline. So you have to do an osteotomy. So that is one indication. Another one is to widen a very narrow bony pyramid. If this bony pyramid is too narrow, we have to widen it by doing an osteotomy. Okay, to widen narrow bony pyramid. Bony part. Okay. And the third indication is narrow or straighten a wide or a deviated nose. Okay. Either you have to narrow or you have to straighten a very highly deviated or a very wide nose. Okay. So a wide nose. So these are the three indications of an osteotomy. And what are the types of osteotomy? Again, there are three types of osteotomy. It can be a medial osteotomy, or it can be a lateral osteotomy, or it can be a intermediate osteotomy. Medial osteotomy. Again, this medial osteotomy can be a medial oblique osteotomy, or it can be a medial vertical osteotomy. So it can be either oblique type or it can be a vertical type. As you can see here, this is a midpoint junction of the two lateral nasal bones. So this medial osteotomy is ideally done here. So this is a medial oblique osteotomy, or it can be exactly at the center, can go through this. So it becomes a medial vertical osteotomy. Okay, so a medial oblique osteotomy, or it can be a medial vertical osteotomy, and this you can be done as a continuous osteotomy. Okay, that is, you put the osteotome here and chisel it in a continuous pattern. Only the lateral osteotomy can be done with a in an intermittent fashion. Okay, so usually the medial osteotomies are done in an internal continuous manner, and the indication are again for mobilization of the entire nasal side wall. You want to mobilize the side wall of the nose entirely. So do an incision or an osteotomy in the midline, or preventing an uncontrolled or an irregular back fracture from upper portion of a lateral osteotomy. What will happen if we put a medial osteotomy? We are putting an incision in the midline, in the bony nasal bone. So what will happen? This entire lateral wall can be mobilized. So that is again an indication of this. One is for mobilization of the entire lateral nasal side wall. And second indication is, if we are putting an lateral osteotomy, there is chance of an back fracture from the tense lateral. This central part is tensely adhered. So we are putting an incision on the lateral side wall. So there is chance of a back fracture. So in order to prevent that an uncontrolled or an irregular back fracture from the upper portion of the lateral osteotomy, we can put a medial osteotomy. Okay, and also this, if the bony vault is very much narrow, if you want to widen it, then again we can do a medial osteotomy. So the indications of a medial osteotomy are three. One is mobilization of the entire nasal side wall. Second is to prevent an uncontrolled or an irregular back fracture from the upper portion of a lateral osteotomy, or to widen an overly narrowed bony nasal wall. Okay, this is lateral osteotomy. As the name suggests, it is on the lateral nasal bony wall. You can just think and say, close and open dorsum. See, if this area is open after doing a hum reduction, the roof is open, then we can do a osteotomy on the lateral wall and push it in the midline and can close it. So actually this lateral osteotomy, it goes like this. Lateral osteotomy can be high type of lateral osteotomy or low lateral osteotomy. That is, If you are drawing the lateral nasal wall, lateral view, the bony nose, then comes our pyriform aperture and the spine of maxilla, and it will go like this. Okay, and here comes the orbit. So this part, and here will be the upper lateral cartilage and the lower lateral cartilage, and draw a line from this glabella up to the pyriform aperture. If your osteotomy is above this line, it becomes a high osteotomy, and if it is below this, it becomes a low lateral osteotomy. And again, there are two basic techniques. One is a linear single cut technique. Or it can be a perforating technique. Linear single cut is usually done through intranasal or intraoral. We keep the chisel inside, and with that through the nose or intraoral route we put a single cut here, and it will be extended. So instead of doing like this, it will be a single cut. Okay, so that is the linear single cut technique. And perforating technique is usually done percutaneous using micro osteotomes. There we put the micro osteotome here and put multiple perforations, and later these multiple perforations are made into a single one. Okay, that is, this perforating technique is usually done percutaneously using micro osteotome. The third type of osteotomy is an intermediate osteotomy. That is between the medial osteotomy and lateral osteotomy. It comes here, intermediate one. Actually this lateral, it goes lower down. Okay, it goes here. It comes and joins in the pyriform aperture below the upper lateral cartilage, and the intermediate one is actually coming and blending with the upper lateral cartilage. Okay, so that is the difference. Medial one, lateral one, and the intermediate one. The intermediate osteotomy is indicated to narrow an extremely wide nose that has got a very good height. Okay, so intermediate osteotomy is usually done bilaterally. So done in a case of very good height nose with a very good height. And also this is done to correct a deviated nose with one side wall longer than the other. Okay, so one side wall longer than the other side. To correct that, we go for an intermediate type. Intermediate. And also a markedly convex nasal bone. It is better to go with an intermediate type. And the next important one you should remember in rhinoplasty is different types of graft. Especially the spreader graft. That is important one. Spreader graft. There are so many other grafts like batten graft or columella stud graft, and among these, the workhorse in a case of middle vault reconstruction is a spreader graft. Middle vault comes in this area, middle vault, that is the lower part of bony nasal bone and also the upper lateral cartilage. Why it is important? Because the internal nasal valve comes in that area. And in the middle vault area, the surgical result will be minimized by so many reasons, especially a very thin skin or a long and weak upper lateral cartilage or a very short nasal bone, or it can be an tension nose or an anteriorly placed inferior turbinate, or if in a preoperatively you are getting a Cortill's test as positive. Cortill's test, I think I hope you know, the one which we do, we retract the cheek upwards and laterally to find out whether the block is at the nasal valve area. This green comes the nasal septum and upper lateral cartilage. It is and in between this upper lateral cartilage and the nasal septum comes a spreader graft. This red shaded is a spreader graft. It increases the internal nasal valve angle. So diagrammatically we can draw the nasal septum and the upper lateral cartilage like this. Usually the inferior turbinate comes here, and this area is the internal nasal valve area. Nasal septum, inferior turbinate and upper lateral cartilage, this part. So here we are removing this much area and we keep the spreader graft in between this. I am putting on one side and see the result. So it comes like this. So compare with the opposite side where I have not put the spreader graft. See, the nasal valve area is widened. So an aesthetically and functionally better nose will be obtained if you put a spreader graft. And this spreader graft increases the internal nasal valve angle. This is usually a rectangular bar of nasal cartilage, septal cartilage, or can be congal cartilage or rib cartilage, and usually it is 2 to 3 centimeters long with dimensions of 3 to 5 millimeter wide and 1.1 to 1.5 millimeter thick. Okay. They are also available in market as Ristylane, that is hyaluronic acid, okay, and radius or calcium hydroxyl appetite, or it can be in high density porous polyethylene, that is Medpore, high density porous polyethylene or Medpore, and polymer of polylactic and polyglycolic acid, it is lactosorb. So hyaluronic acid, then calcium hydroxyl appetite or high density porous polyethylene, polymer of polylactic and polyglycolic acid. Okay, these are available in the market. Otherwise, you can also use the nasal septal cartilage or the congal cartilage or the rib graft. Typically, they are kept in between the upper lateral cartilage and the nasal septum, and it is very critical, and you should be very careful to extend the spreader graft to cover the key area. Okay, so here comes the key area, this part. So this should extend under the nasal bone and it should extend up to the key area, especially under the nasal bones. Suture. Here we suture it. Okay, it is sutured using a 5-0 polydioxanine sutures. Okay, so what is a spreader graft? It can be either cartilage of the nasal septum or the congal cartilage or the rib cartilage, or it can be available in the market in all these styles, and it's usually these are the dimensions of that, and it is kept between the upper lateral cartilage and the nasal septum, and it should be extended to cover the key area, especially under the nasal bones, and sutured using a 5-0 polydioxanine sutures. Okay. As a recent advance, the auto spreader grafts are also available, and there are also other grafts like an alar batten graft, then there are the H graft, and auto spreader flaps are there, double layered stepped spreader graft are there. You should be aware of them also, because this different graft used in rhinoplasty can again ask us to talk about. Graft, we discussed about the graft, and then the post-op care. Post-op care is similar to that of after septal surgery or any fracture nasal bone reduction. Complications. As in all other surgeries, complication we can divide into at the time of surgery and post-operative. At the time of surgery, we can again divide into that because of anesthesia and that because of surgery itself. And anesthesia complications, it is similar to all other surgeries like drug allergy or cardiac arrest, etc. The intraoperative main complication is hemorrhage, and post-operatively similar to all other surgeries, it can be a wound infection or it can be a septal hematoma, and later on it can go for septal abscess or septal perforation, and nasal obstruction, nasal deformity or toxic shock syndrome. Regarding the nasal obstruction, it can be early obstruction can be due to mucosal edema and nasal crusting. That you can reduce either by giving steroids or by giving saline nasal drops. And in late cases, the nasal obstruction is mainly due to a septal deviation or nasal valve narrowing, or can be vestibular scarring, especially the columellar retraction, especially if you are going for an open or a columellar incision, or alar collapse, or the overcrowding of the intranasal structures. All these will lead to a late nasal obstruction. And nasal deformity is mainly a saddle nose deformity if there is an overcorrection or a narrow dorsum. Regarding the nasal, a late complication as nasal deformity can be a polypic deformity or drooping of the tip. All these complications occur if you are going for a tipplasty. And remember, tipplasty is a thing which you need very high expertise. And the learning curve of all this rhinoplasty, especially the tipplasty, is very high. Okay. And then drooping of the tip, then again thick columella or caudal septal deviation, and uneven dorsum or a saddle nose deformity. All this can happen as a late complication. So this is regarding rhinoplasty in a nutshell. So we discussed about the indications, then preoperative assessment, the importance of documentation, then the sequence of operation, incisions, different types of osteotomies, graft, mainly the spreader graft, post-operative care, and also the complication. And if you need any technique in detail, just ask me in the comment box. Thank you.